Hi, this is Dr. Poole, and this talk will cover inherited metabolic liver diseases, including hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency. The first topic is hemochromatosis, in which there's too much iron. Iron overload, or hemosiderosis, is a potentially serious problem that's often overlooked because the symptoms are nonspecific and often develop gradually. Once iron overload is diagnosed, the options for treatment are relatively straightforward. But if left untreated, individuals can develop life-threatening toxicity. Thus, it's important to identify iron overload early. Hemochromatosis is caused by excessive iron absorption, most of which is deposited in parenchymal organs such as the liver and pancreas, followed by the heart, joints, and endocrine organs. Hereditary hemochromatosis, most commonly due to mutations in the HFE gene, is an autosomal recessive disorder in which there's increased intestinal iron absorption, and that's going to be the focus for the rest of this section. There are, however, a number of secondary causes of iron overload that are important to consider in suspected iron overload, and this is a table which outlines some of these different causes and their mechanisms. Note that the cause can be either increased intake of iron or increased absorption. Hereditary hemochromatosis was thought to be rare, since it was only identified clinically when patients developed full-blown bronzed diabetes. Once it was appreciated that hereditary hemochromatosis was transmitted as an autosomal recessive trait, more accurate family analyses could be performed, and more sophisticated biochemical tests became available that could identify the presence of an abnormality in iron metabolism, even in those persons that didn't display the classic full-blown clinical picture. Using cutoff values for transferrin saturation of greater than 60% in men and over 50% in women, identified the frequency of heterozygotes as approximately 10% in European Americans, with a frequency of about 5 per 1,000, or 0.5%, for the homozygous state. This is about 31 times more prevalent than in African Americans, and 11,000 times more than in Asian Americans. The adult form of hemochromatosis is almost always caused by mutations of HFE. Mutations of TFR is far less common. The HFE gene is located on the short arm of chromosome 6, close to the HLA gene locus. It encodes an HLA class I-like molecule that regulates hepcidin synthesis, and so affects intestinal absorption of dietary iron. The most common HFE mutation is a cysteine to tyrosine substitution at amino acid 282, called C282Y. This mutation, which causes inactivation of the protein, is present in 70 to 100% of patients diagnosed with hereditary hemochromatosis. The other common mutation is H63D, where histidine at position 63 is changed to an aspartate. The H63D homozygous state and C282Y H63D compound heterozygous mutations often cause only mild iron accumulation. This mutation, however, is notable because it has a worldwide distribution, as opposed to the C282Y mutation, which is almost exclusively confined to people of European origin. This slide shows a comparison between normal iron absorption and what happens in hemochromatosis. Now you're going to go over iron metabolism in a lot more detail in a subsequent course, but for right now I just wanted to use this illustration to show you some of the pathophysiology behind hemochromatosis. If you'll note at the bottom, these receptors, most notably HFE1, has an effect on reducing hepcidin synthesis. These other receptors can also be mutated in hemochromatosis, but is much less frequent, as we mentioned before. So what happens is that there's reduced hepcidin synthesis, and as a result, there's decreased circulating hepcidin, which reduces the hepcidin-ferroportin interaction and allows for increased ferroportin activity, which increases the absorption of iron into enterocytes, giving rise to systemic iron overload in hereditary hemochromatosis. The clinical manifestations of hereditary hemochromatosis are related to excessive iron deposition in tissues, especially the liver, heart, pancreas, and pituitary gland. The retained iron is primarily deposited in parenchymal cells, with reticuloendothelial cell accumulation occurring very late in the disease. This is in contrast to transfusional iron overload, perhaps the most common cause of secondary hemochromatosis or hemosiderosis, in which iron deposition occurs first in the reticuloendothelial cells and then in parenchymal cells. The classic clinical manifestations of iron accumulation include liver disease, skin pigmentation, diabetes mellitus, arthropathy, impotence in males, and cardiac enlargement with or without heart failure or conduction defects. You might remember that hemochromatosis was mentioned as a secondary cause of dilated cardiomyopathy in the vital fluids course. As mentioned earlier, iron overload is frequently underdiagnosed because the symptoms are nonspecific and often develop gradually. It's been recognized that symptoms had been present for an average of 10 years before diagnosis in a substantial number of patients. The classic features at presentation are listed here and classically include liver function abnormalities, skin hyperpigmentation, and diabetes mellitus, as well as the others listed. Because of increased recognition and more sensitive biochemical tests, as mentioned, the presentation of hereditary hemochromatosis has changed. Most patients are now currently diagnosed when elevated ferritin levels or increased transferrin saturation are found, or because screening is performed because a relative is diagnosed with hereditary hemochromatosis. So the result is approximately 75% of patients are now diagnosed by abnormal screening tests and are asymptomatic at presentation, and only a low incidence, less than 25%, have the classic clinical findings of cirrhosis, diabetes, or skin hyperpigmentation at diagnosis. Progressive iron deposition in the liver is associated with hepatomegaly, elevated liver enzymes, and the eventual development of increasing fibrosis and cirrhosis. With respect to elevated liver enzymes, the deposition of excess iron alone in the hepatocytes of individuals with hereditary hemochromatosis is not inflammatory. Thus, hepatic fibrosis occurs in some subjects with hereditary hemochromatosis and normal levels of serum transaminases. So there are some important caveats. The diagnosis of hereditary hemochromatosis is still tenable, even if transaminases levels are normal. In addition, patients with hereditary hemochromatosis often have an additional cause of chronic inflammatory liver disease. And finally, genetic screening for hereditary hemochromatosis should always be considered in patients with known chronic inflammatory disease because of this former point. Reversibility of these changes following therapeutic iron removal is more likely early in the course of disease, as you might expect, but can occur even in patients with cirrhosis and portal hypertension. The presence of hereditary hemochromatosis-induced iron overload may also have a potentiating effect on hepatic fibrosis in patients with HH accompanied by hepatitis C virus infection. Diabetes mellitus is a complication due to progressive iron accumulation in the pancreas. The defect appears to be relatively selective for the pancreatic beta cell, Insulin and C-peptide secretion are reduced, but alpha-soft function seems to be intact, as evidenced by increased serum glucagon levels similar to those seen in type 1 diabetes. It's important to note that although diabetes does not usually improve following treatment with phlebotomy, insulin level or insulin requirements may be decreased. The main morphologic hallmark in the liver in hereditary hemochromatosis is hemosiderin deposition. This is noted first in periportal hepatocytes, as these are the first to encounter the portal blood, but then there's progressive involvement of the rest of the lobule, as well as the bile duct epithelium, and finally the Kupffer cells, the reticuloendothelial cells in the liver. Hemosiderin deposition can be identified with Prussian blue stain for iron. Again, inflammation is typically absent. Fibrosis develops slowly and leads to micronodular pattern of cirrhosis. Grossly, the liver progressively becomes dark brown or even black because of the massive deposition of hemosiderin in the liver. In the image on the left, which is a routine H&E stained section, you can appreciate abundant brown pigment within the cells of these hepatocytes, as well as developing fibrosis between the nodule. On the right is how we identify this pigment as specifically iron, using the Prussian blue stain, which stains the hemosiderin granules blue. And this is diagnostic for hemosiderosis. The extrahepatic pathologic hallmarks follow a similar pattern. In the pancreas, there is intense pigmentation as well as diffuse interstitial fibrosis, and hemosiderin can be identified in both acinar and islet cells. Again, the heart is affected by hemochromatosis or hemosiderosis as a dilated cardiomyopathy, and you can identify hemosiderin in myocardiocytes. The skin is a little bit different in that the increased pigment is primarily due to melanin, due to some unknown mechanism, but you can find hemosiderin in dermal macrophages and fibroblasts, which also contributes to the hyperpigmentation. The simplest, cheapest, and most effective way to remove accumulated iron in non-anemic patients with iron overload is via therapeutic phlebotomy. Each 500 milliliter collection of whole blood, a usual blood donation, removes 200 to 250 milligrams of iron. In providing replacement for the hemoglobin lost, along with the phlebotomized red cells, the body mobilizes an equal amount of iron from tissue stores, thus reducing the degree of iron overload. Erythrocytophoresis is an apheresis technique whereby red cells are removed in an isovolemic manner and the patient's plasma is returned to the patient. Finally, the use of iron chelating agents, listed there, for the removal of excess iron in patients with hereditary hemochromatosis can lead to clinical and/or laboratory improvement. However, this is almost never necessary because of the ease and efficacy of phlebotomy compared to chelation therapy. My next topic is Wilson disease, in which there's too much copper. Wilson disease is also an autosomal recessive disorder, but is caused by mutation of the ATP7B gene. This results in impaired copper excretion into bile and a failure to incorporate copper into ceruloplasmin, which is the circulating copper-bound protein. It's marked by accumulation of toxic levels of copper in many tissues and organs, but principally in the liver, brain, and the eye. The prevalence of Wilson disease is much less than either hereditary hemochromatosis or the other disease that I'll talk about, alpha-1 antitrypsin deficiency. There's a prevalence of approximately 1 case in 30,000 live births in most populations worldwide. Let me review a little bit about normal copper metabolism. Dietary copper intake is approximately 1 to 2 milligrams per day, while the daily requirement for copper is approximately 0.75 milligrams. Copper is absorbed in the stomach and duodenum, binds mainly to circulating albumin, and is then taken up by the liver and various other tissues. Excess copper is predominantly excreted by the liver into the bile, where it ends up as fecal copper. The transport of copper within hepatocytes is regulated by ATP7B, the copper transporting intracellular protein affected in Wilson disease. ATP7B mediates the transport of copper for the incorporation of 6 copper atoms into apoceruloplasmin, that is, the ceruloplasmin peptide without copper, to form ceruloplasmin, which is then secreted into the bloodstream. In this form, copper in ceruloplasmin is not exchangeable under physiologic conditions. The copper in this molecule is necessary for its function in iron metabolism as a ferroxidase, and this accounts for approximately 90% of circulating copper. In hepatocytes, ATP7B-mediated copper transport sequesters excess copper into vesicles, which is then excreted into bile. So Wilson disease is the result of mutation in ATP7B, the gene that encodes the copper transport protein, and is located on chromosome 13. ATP7B can be affected by mutations at many different sites. Over 500 different mutations in the ATP7B gene have been identified in patients with clinical Wilson disease. Most patients, interestingly, are compound heterozygotes, carrying different mutations on each copy of chromosome 13. Accumulated copper causes liver injury by promotion of free radical damage, the binding of sulfhydryl groups to cellular proteins, rendering them inactive, and displacement of other metals from hepatocyte metalloenzymes, reducing the metabolic capacity of hepatocytes. The clinical manifestations of Wilson disease are primarily hepatic, neurologic, and psychiatric, with many patients having a combination of symptoms. We will revisit Wilson disease again in the Brain, Behavior, and Cognition course, and I'll focus now on how copper accumulation affects the liver in this presentation. Patients may present with a wide variety of symptoms, especially those patients with neurologic symptoms. The liver is the initial site of copper accumulation in patients with Wilson disease, and there are several different clinical manifestations of hepatic copper accumulation. Hepatic manifestations range widely and include asymptomatic biochemical abnormalities and steatosis, acute hepatitis and acute liver failure, chronic hepatitis, and cirrhosis. Regardless of the presenting symptoms, some degree of liver disease, even if only histologic change, is usually present at the time Wilson disease is diagnosed. The signs, symptoms, laboratory findings, and imaging findings in patients with hepatic Wilson disease vary with the degree of liver damage. This was a list of the signs and symptoms of hepatic Wilson disease. I'm not going to read all of them off to you, but just note that there's some key signs and symptoms. First is Kaiser-Fleischer rings. These are visible in 50% of patients with hepatic disease and occur in all forms of liver involvement. Of course, patients may be asymptomatic and detected only by a biochemical abnormality or silent steatosis, chronic hepatitis, or compensated cirrhosis even. There's a variety of signs and symptoms that are associated with hepatitis and acute and chronic liver disease. And then don't forget mental status changes, which may be due to hepatic encephalopathy or direct toxicity of copper to the brain itself. I put this slide in just to demonstrate the Kaiser-Fleischer ring. This is a ring of brown, golden brown copper deposition, which is in the periphery of Descemet's membrane and partially obstructs, as you see, the underlying iris. The most specific laboratory findings in Wilson disease are a low level of serum ceruloplasmin, which you'll see in all forms of liver involvement. The most sensitive screening test is increased urinary excretion of copper. And the most specific and confirmatory test is increased hepatic copper content, which is diagnosed by taking a sample of liver and doing metal analysis for copper. There's a number of nonspecific laboratory findings that are just confirming the presence of liver involvement, including elevated aminotransferases, thrombocytopenia, and coagulopathy with advanced liver disease. A variety of nonspecific morphologic changes are seen in Wilson disease, including steatosis, acute fulminant hepatitis with massive hepatocellular necrosis, chronic hepatitis, and cirrhosis. The diagnostic findings are excessive copper deposition, which is identified by special stains, including rhodamine, which stains copper, and orcine, which stains copper-associated protein. Because Wilson disease has such a variable histologic picture, the real diagnostic hallmarks are identifying copper or the copper-binding protein in liver. So the image on the left is a rhodamine stain which identifies copper directly, while the orcine stain, which is probably used more commonly, is a stain for the copper-binding protein. Again, with extrahepatic pathologic hallmarks, we'll talk a lot more about Wilson disease in the brain behavior and cognition course. And then remember the diagnostic eye findings, the Kaiser-Fleischer rings. Management of Wilson disease includes copper chelation therapy, most commonly with D-penicillamine. You can also use zinc-based therapy, which blocks copper uptake from the gut. And once patients are cirrhotic or have advanced chronic liver disease, liver transplantation is quite successful in managing the disease. My final section is alpha-1 antitrypsin deficiency, which is the result of a toxic gain of function, which results in the accumulation of the defective alpha-1 antitrypsin protein. Alpha-1 antitrypsin deficiency is also an autosomal recessive disorder, but instead of the accumulation of a toxic metal, this is due to the accumulation of a abnormal protein. Very low levels of functional alpha-1 antitrypsin is something that led to pan-acinar emphysema, which I talked about and you learned about in the vital gases course. But alpha-1 antitrypsin disease also causes liver disease because the accumulation of the defective protein in hepatocytes. Abnormal or mutations in the alpha-1 antitrypsin gene are fairly common, although the disease or the clinical phenotype itself is, as you would expect, somewhat less common. It's estimated that 80,000 to 100,000 individuals in the U.S. have severe deficiency of alpha-1 antitrypsin, although the deficiency is considered to be quite rare. About 40 to 60,000 Americans are expected to have pan-acinar emphysema caused by alpha-1 antitrypsin deficiency. Based on studies that show severe deficiency of alpha-1 antitrypsin is found in about 2 to 3% of patients with chronic COPD, if you look for it. The prevalence of individuals with the deficient phenotype and resultant severe deficiency of alpha-1 antitrypsin ranges from 1 in 1,575 to 1 in 5,097 individuals. All of this suggests that the phenotype and possibly the clinical disease of alpha-1 antitrypsin deficiency is under-recognized. I've always found the genetics of alpha-1 antitrypsin deficiency to be a little bit difficult, so I thought I'd spend a little time explaining some of the nomenclature because it doesn't really follow the usual conventions. The gene that encodes alpha-1 antitrypsin is called SERPINA1 and is located on the long arm of chromosome 14. Alpha-1 antitrypsin is a protease inhibitor and a member of the serpin family of proteins. At least 150 alleles of SERPINA1 have been identified. Again, the nomenclature for alpha-1 antitrypsin deficiency is somewhat awkward. Each of these alleles has a letter code that's actually based on the electrophoretic mobility of the protein produced. The normal allele is referred to as M. PI denotes protease inhibitor, which is what alpha-1 antitrypsin is, and then the letters denote the alleles that are present. Thus, a person with a normal gene that is homozygous for M would be PIMM. Normal alpha-1 antitrypsin is inherited by an autosomal codominant transmission, meaning you get one allele from each parent. Homozygosity for the Z allele is the most common mutation in SERPINA1 gene that leads to alpha-1 antitrypsin deficiency, and this allele is carried by approximately 2 to 3% of the U.S. population. The Z point mutation is a substitution of lysine for a glutamic acid at position 342 on the alpha antitrypsin molecule, which happens to be in the hinge region of the alpha-1 antitrypsin molecule, and this causes an increased tendency to polymerization and aggregation. Other common alleles that can lead to intracellular accumulation of alpha-1 antitrypsin are S and M. Similar to Wilson disease, some individuals have compound heterozygosity. It's a critical point to understand that the pathogenesis of the liver injury in alpha-1 antitrypsin deficiency differs from that of pulmonary disease. Pulmonary disease is primarily due to a so-called toxic loss of function abnormality, that is, destruction of elastin by elastase and other proteases in the alveolar walls, the activity of which is increased because of a deficiency of the opposing elastase inhibitor alpha-1 antitrypsin. Polymers of Z-type alpha-1 antitrypsin protein have also shown to be chemotactic for neutrophils, which further contributes to alveolar wall destruction. In contrast, liver disease is caused by a toxic gain of function, in which intrahepatocyte accumulation of mutant Z-type alpha-1 antitrypsin molecules within the rough ER results from abnormal folding and aggregation of these molecules in a mechanism called loop sheet polymerization. It's unclear how the accumulation of Z-type protein within the rough ER, though, causes liver cell injury. Neonates and children are affected with neonatal hepatitis. In adults, about 40% of PIZZ patients may develop either chronic hepatitis with progression to cirrhosis and are at increased risk for developing hepatocellular carcinoma. The morphologic hallmark in the liver are the presence of numerous distinct round eosinophilic intracytoplasmic inclusions located in periportal hepatocytes. Key to the diagnosis is positive staining with the PAS stain after diastase digestion, which stains these intracytoplasmic inclusions. Note that the diastase digests glycogen, but it does not digest the misfolded mutant alpha-1 antitrypsin protein, so that's why it's useful for distinguishing this. You can also confirm the presence of alpha-1 antitrypsin by immunohistochemical stain. Cirrhosis may be either micronodular or a mixed macro and micronodular pattern. This image shows the presence of these intracytoplasmic eosinophilic globules within the cytoplasm of a periportal hepatocyte. This is the portal area on this end of the image. More classic are the presence of these round eosinophilic globules which characteristically have a surrounding clear halo or space. And this image shows the clincher for the diagnosis. The presence of these bright red-purple intracytoplasmic inclusions with the PAS stain after diastase digestion. And then you can confirm it with a specific antibody using immunohistochemistry to alpha-1 antitrypsin. The main extrahepatic pathologic hallmark you already know about from vital gases. The features of emphysema associated with severe alpha-1 antitrypsin deficiency are distinctive from the usual COPD, as you learned before. First of all, it has the pan-acinar pattern, but also emphysema occurs at a young age. It occurs in the absence of smoking or occupational risk factors, and is characterized predominantly by basilar changes on chest imaging, as opposed to the usual emphysema associated with COPD, which occurs in older adults almost exclusively with a history of smoking or other occupational risk factor, and is predominantly affects the upper lung fields. The diagnosis of severe deficiency of alpha-1 antitrypsin is confirmed by demonstrating a serum level below 100 milligrams per DL in combination with identification of a severe deficient phenotype, generally determined by isoelectric focusing, identifying the phenotypic characteristics of the protein, or by direct genotyping, assessing for the most common deficient alleles. There's no specific treatment for alpha-1 antitrypsin associated liver disease, as the mechanism of liver injury is the accumulation of mutant Z protein or other mutant proteins associated with accumulation in hepatocytes rather than a protease deficiency itself. So the main treatment is just supportive measures, as you would for any patient with chronic liver disease, and similar to Wilson disease, liver transplantation is quite successful. Okay, this is a summary slide of the main points of this presentation. I won't read them to you, but we've talked about hemochromatosis, Wilson disease, and alpha-1 antitrypsin disease as the main inherited causes of metabolic liver disease.